Please note that this session will be recorded. Please mute your microphone at this time, and we'll hold all questions and comments until after the presentation, at which point the recording will be stopped and we'll begin our discussion. So to start, welcome everyone to our session today of the 2025 Global Collaborative Series, Aligning Advanced Practice Nursing with Global Sustainable Development Goals. This monthly event is made possible through the generous collaboration of our esteemed partners, hosts. I am one of them. I'm Professor Jean-Marie Staccherini, Associate Dean for Global Affairs and Director of the Pan American Health Organization of the World Health Organization Collaborating Center at the University of Michigan School of Nursing. Dr. April Kapoor, Professor and Associate Dean for Strategic Partnerships and Global Affairs at Vanderbilt University School of Nursing. Dr. Asia Nippon, Director of Global Affairs and Planetary Health at Yale School of Nursing, and Dr. Megan Allen from Yale School of Nursing. Thank you all to our partners for their dedication and contribution to this initiative. Each month, we'll take turns hosting this important series, and we encourage everyone to stay engaged by registering for future sessions. Now, it's my pleasure to introduce today's speaker, my colleague, Dr. Michelle Moreau-Kramer. She's going to be presenting today, and the title is From Theory to Practice, Integrating Education and Intervention to End Violence Against Women and Girls. Dr. Moreau-Kramer is an associate professor and director of global programs at the University of Michigan School of Nursing. She graduated with a PhD and MS in nursing from the University of Michigan and earned her BSN at Michigan State University. She's certified as a family nurse practitioner, as a nurse midwife, and sexual assault nurse examiner. Her program of research focuses on gender-based violence prevention and response, primarily among college-age youth within domestic and also international contexts. She's interested in leveraging nurses' creativity to develop innovative solutions to complex health and human rights issues such as intimate partner violence, sexual violence, and human trafficking. Her research project approached these topics using a trauma-informed and patient-centered lens with the goal of understanding the experiences of vulnerable populations to inform intervention development. She is currently working with colleagues at university campuses across 6 countries in sub-Saharan Africa as part of the Subvert network to develop evidence-based policies, measures, and intervention to address gender-based violence among university students. Dr. Moreau-Kramer developed the first undergraduate elective course at the University of Michigan focused on gender-based violence. She's also part of the team developing and evaluating a new course on sexual citizenship for incoming students at the University of Michigan. In collaboration with a group of interdisciplinary colleagues from the University of Michigan and University of Maryland, She helped create a massive open online course, more intimate partner violence, interprofessional strategies for prevention and response. Also, as part of the University of Michigan Human Trafficking Collaborative, she's also co-developed a continuing education module on human trafficking for healthcare providers, addressing human trafficking in healthcare settings. Please join me in giving a warm welcome to Dr. Michelle Muro-Kramer as she shares her expertise with us.
Thank you very much, Dr. Saccarini, for that warm welcome and for inviting me here to speak a little bit more about violence against women and girls, or gender-based violence, and the role of the advanced practice nurse. So I already have a very detailed description of my background, but just wanted to say a little bit more, that I became very interested in this topic because of my clinical work. So I've been a nurse for 22 years and a family nurse practitioner and certified nurse midwife for the last 19 years. And it was really the clinical work, screening and supporting women in a women's health clinic, where the impacts of violence became more apparent to me in my role as an advanced practice nurse. And so I was practicing at the time that emergency contraception, so Plan B, became an over-the-counter product. And screening for violence was part of my practice at the time. And I found that I actually had a lot of patients who had experienced violence. And when that product became over the counter, they were using it for pregnancy prevention, but not necessarily considering some of the other health impacts of violence. And so I became really interested in decision making after experiences of intimate partner or sexual violence, and how individuals decide whether or not to seek care and kind of how to seek care. So that is what led me back to school to pursue a PhD in nursing. And I've continued focusing on gender-based violence very broadly throughout my last decade of time focusing on research. And then I also will bring in the education piece. Having expertise in intimate partner and sexual violence has been very useful, I think, for myself and my colleagues, where I am able to provide guest lectures quite frequently to many of our graduate and undergraduate students. And so we'll spend a little time talking about, what that means in regards to our role in addressing gender-based violence in the healthcare system. So to get us started, we are focusing on sustainable development goals. And I just wanted to highlight how gender-based violence really intersects with many of the current sustainable development goals. So first of all, gender-based violence is a pervasive public health crisis worldwide. It is happening everywhere, and the rates of violence have remained relatively unchanged over the last couple of decades. And so when the Sustainable Development Goals were created, gender-based violence was actually woven in a few different areas. So Sustainable Development Goal 3 focuses on good health and well-being. And really, this recognizes that achieving good health for all requires addressing the health consequences of violence, including intimate partner violence, sexual violence, and also child maltreatment. SDG 5, gender equality, has a specific target, 5.2, which actually aims to eliminate all forms of violence against women and girls. Unfortunately, we are not going to address that target by 2030, but it is certainly something that has been recognized, by member countries, by individuals globally, as a goal that needs to be addressed. SDG 10 focuses on reduced inequalities. And so this is really intrinsically linked to different forms of gender-based violence because gender inequality is a root cause and a major societal level risk factor for different forms of violence. We'll talk a little bit more about the definition of violence, but violence is often used to really enforce or perpetuate some of the unequal power dynamics that exist in many societies. And then SDG 16 is focused on peace, justice, and strong institution. And so this is really aiming to reduce all forms of violence, including violence against women and girls, through targets like reducing death rates and providing access to justice for all victims. And while justice is a really big word and can look different, it still is really focused on the resources and supports that individuals might need after experiencing violence. So, what I'd like you to think about during the presentation today is that advanced practice nurses, and really all nurses, are uniquely positioned to lead intervention efforts across settings. In fact, nurses have long led the charge to improve practice and research related to gender based violence because of their unique role in the lives of their patients, recognizing really that interaction between violence and health outcomes. And many of the individuals who I have read or who I have worked with are nurses and have really done some pivotal work influencing both clinical guidelines and some of the research in this area. So, when I say the term gender based violence, what I am referring to is a harmful act that is directed against a person because of their gender. So, again, this is rooted in gender inequality and really perpetuating inequalities in power and control. While disproportionately affecting women and girls, gender based violence can also negatively impact individuals of any gender identity. And the types of violence that could occur could start in childhood as childhood abuse or child abuse or maltreatment, and range throughout the life course, encompassing things such as child marriage, human trafficking, female genital cutting, stalking, sexual violence, intimate partner violence, and elder abuse. So, one of the other things I'd really like us to think about is this kind of life course perspective where we might see different forms of violence or abuse depending on the age of the individuals that we're working with. Um, Ultimately, these different forms of abuse do have pretty significant health outcomes. We also know that they sometimes distinctly occur in populations that have kind of multiple overlapping forms of inequality. So, this might be related to race, class, ability status, or sexual orientation. So, when we're thinking about gender based violence, it's important to recognize that really anybody can be at risk, but there are some populations that do experience kind of an undue burden of violence as well. The other thing to consider is that violence does not happen in a vacuum. It really occurs within our individual lives that are part of relationships, communities, and ultimately society. And so much of the work that's focused on gender based violence has used really this ecological model of violence prevention. This particular model on this slide is from the Centers for Disease Control in the United States, but really recognize that violence emerges from this kind of interaction or interplay of individuals within kind of interpersonal relationships within communities that are ultimately influenced by societal norms, cultural norms, and factors. The other thing I'd like us to consider is violence really as a violation of fundamental human rights. And so when we're thinking about interventions and approaches to address violence, some of this will focus very much on our roles as, nurses, nurse practitioners, and what that individual patient interaction might look like. But we also need to think more broadly, often focusing on policies, both at the system level as well as the societal level. and how those really kind of define and provide resources for individuals who've experienced gender-based violence. And then finally, I just want to highlight the role of trauma-informed care. I think one of the most important things as a healthcare practitioner is really understanding that we cannot look at somebody and know who has experienced violence in their lifetime or even more recently. And so a trauma-informed care approach really understands that widespread impact of trauma. It uses this approach kind of in all interactions, recognizing that we may not know who has experienced trauma in some settings, and it really promotes physical, psychological, and emotional safety for those individuals we're interacting with, as well as for ourselves. So really centering healthcare providers as well, knowing that we can't help someone if we are in an environment or a situation which is unsafe. So we'll come back to trauma-informed care a bit later about how that applies to interactions with individuals, but overall is a useful framework to guide our discussion today about gender-based violence. I mentioned on one of the first slides that we really haven't seen a change in the experience of violence over the last couple of decades. And so one of the statistics that really supports this is from the World Health Organization that looks at the global prevalence of intimate partner violence and or sexual violence by a partner or non-partner. And it continues to show a rate of 1 in 3 women, with slightly higher rates in some regions of the world. The long-term consequences of this violence can result in a variety of things, such as chronic conditions, chronic pain, mental health conditions, reproductive health issues, as well as social and economic kind of instability. We also have seen some research that there are certain things in our environment that can exacerbate risks related to gender-based violence. So there's been increasing focus on disasters and climate change and how those might be impacting relationships and experiences of violence. And then there was also a lot of research during the COVID-19 pandemic. Some of it has indicated an increased risk of gender-based violence and was termed the shadow pandemic. And then some newer research is really questioning whether it was an increased risk or really just a change in the way we were kind of screening and providing resources during that time. Regardless, we know that there are changes happening globally that will continue to impact experiences of violence among individuals across the world. And then lastly, I just want to highlight that we know gender-based violence is also chronically underreported. And this can be for a variety of reasons. Sometimes it's related to the definitions and terminology we use. Not everybody would call themselves an intimate partner violence survivor, but instead would maybe describe experiences they've had in their relationship. There's a lot of stigma around violence, especially in certain social and cultural settings. There's often a lack of trust in the systems that are supposed to be providing support and resources. And then in many areas, there's also just insufficient resources to support individuals who've experienced violence. And so when I look at my work, both in the United States as well as in other settings, so working with colleagues in sub-Saharan Africa and also in Pakistan, there really is some challenges in integrating kind of what we know about violence and how to respond with our practice. And so, first of all, there are these kind of deeply rooted sociocultural barriers or gender norms and stigma that really continue to deter reporting and access to care. There also continue to be large gaps in education, and this is for nurses and APNs as well. We often lack training in identification, response, and trauma-informed care related to gender-based violence. If we do receive this education, it's often kind of a one-time lecture, and it's not always something that individuals feel comfortable implementing in practice. This also can vary a lot per region. I have talked to colleagues in other regions where there are limited resources. So, for instance, there, are no shelters. There's really limited kind of mental health support and counseling, and they often feel very ill-equipped to screen and provide support to individuals experiencing violence because they're not sure what they have to offer them. And so I think these policy and resource challenges are also persistent globally, that we often have somewhat inconsistent laws, limited funding, and really just this fragmented services that really create obstacles for one screening, but then also for referring individuals to a more coordinated response for care. It's very daunting to think about providing, comprehensive services to somebody that's experiencing violence if you don't have support networks that you can refer someone to. So, what I'd like to spend a little time on is how could we do a better job preparing kind of the ourselves and also the next generation of advanced practice nurses. When we think about curriculum development, we're very focused on competencies right now. And so I've put a graphic of competencies for universal healthcare coverage from the WHO on the screen. And you can see there are some broad competencies related to people-centeredness, decision-making, communication, collaboration, evidence-informed practice, personal conduct. We have similar competencies for many of our other programs as well. And those competencies often drive what we are teaching our students and how we're evaluating them. We're evaluating them for those competencies. And so what I would love us to think about is how to incorporate content related to gender-based violence, violence specifically experienced by women and girls into our nursing curricula, really moving beyond this elective or guest lecture format to kind of core requirements. I currently teach an undergraduate elective focused on gender-based violence. It is a course that's open to university students across our campus. And I tend to think it's a good course because it really does bring in different viewpoints from students learning in different disciplines. But usually less than half of my class is nursing students. I generally have only a handful of nursing students. And so those undergraduate nursing students that are taking the course are often doing so because they have a sincere interest in the topic or because it also counts towards one of our minors. But that means I'm missing, about 90% of our undergraduate nursing population in that course. As I mentioned, I also give a fair number of guest lectures every year, specifically focused on screening and responding to intimate partner violence and sexual violence. These tend to be based on advanced practice specialty. So I do a lecture for midwifery. I do a lecture for family nurse practitioners. I do a lecture for adult gero nurse practitioners. And again, while this does provide an overview, we work through some case studies. It is a one-time interaction that really just touches on the surface of identification and response when dealing with intimate partner or sexual violence. And so, competency wise, if we could think about what competencies are needed for gender based violence, it would be things like assessment and identification. And this would likely vary depending on the region of the world that you're in. Second would be communication. How do we have survivor-centered communication? How do we focus on this trauma-informed care? And how do we not blame individuals for the violence they've experienced? There would also need to be a focus on collaborating with multi-sectoral partners. So how do we do warm handoffs to those in other settings like shelters, mental health or counseling, and then work with colleagues within the kind of legal or justice system as well. Ways that we could go about providing some of this training could be relying a bit more on simulation. I know some of my colleagues have developed a simulation around intimate partner violence for our advanced practice nurses. And so, really, this use of role play and standardized patients to navigate what are very complex scenarios. So, practicing the terminology that could be used to screen somebody, responding to a disclosure. How do you do that in a empathetic way, really providing eye contact and connecting with the individual who has disclosed to you? And then also, how do you go about safety planning? I've already mentioned case-based learning. I think this, reflecting on real life cases can really help to one, illustrate the complexity of these cases, but also to help foster some problem solving. What would you do in this setting? And really kind of think about the steps in identification and response. Focusing on culturally sensitive and survivor-centered approaches. So really understanding that solutions might be different depending on the region of the world you are in or who you are working with. Not everybody is aiming to kind of exit a relationship that they would might be experiencing violence in. And so training would really need to focus on kind of some of the implicit biases we might have around this, as well as a really intersectional approach focused on empowering the survivors and understanding what their goals are. And then, as I mentioned, a one-time training is generally not enough. So also continuing to focus on professional development. When I give my guest lectures, I always remind the students that this is a quick overview. I'm giving them resources for the future, but also really encourage them to continue their education on this topic so that they can build on and maintain the expertise needed in this area. One of the ways that some of the teams I've worked with have done this is to develop online learning modules. And so one of these was developed in collaboration with University of Maryland and University of Michigan, including nursing and social work and medicine. And we really focused on interprofessional strategies for prevention and response. And so this is a MOOC, or massive open online course that can be taken by anybody around the world through edX. And so there is the option to really just do this for your own learning over time, or to get a certificate that demonstrates that you've had some additional training and expertise in this area. We include clinical guidelines as well as case studies to really provide practical information to learners, and there are a number of interactive activities to built in to ensure that learners are staying engaged and really kind of assess their learning and through some like knowledge-based questions as well as some self-reflection. The other collaborative that I have been involved with was specifically related to human trafficking. And so faculty from the law school, School of Social Work, School of Nursing, and actually the School of Engineering came together to focus on human trafficking. And we developed what we call the Human Trafficking Collaborative. This really came about because the state of Michigan started requiring that nurses and nurse practitioners, and actually anybody in healthcare, so physicians, podiatrists, dentists, everybody, have continuing education training in human trafficking before renewing their state license. When this happened, we found a number of for-profit companies kind of popping up with human trafficking education modules that sometimes perpetuated some of the myths and misconceptions about human trafficking. And so we came together to create a module that met the state objectives with some human trafficking survivors. So, again, really rooted it in survivor voice. We have content related to healthcare, social work, the legal system, and we also have created some videos that include a survivor of both labor trafficking and sex trafficking, so that they could really tell their story. What did this look like for them when they were in the healthcare system? Were people asking questions, or just kind of maybe overlooking some of the signs that they were experiencing harm? This has been an extremely successful collaboration. Last I looked, we had 35,000 people that had taken our educational module. So another way to use our expertise as advanced practice nurses and really get education out to a large group, especially a large group of individuals who are already practicing, right, and don't have the opportunity to learn some of this content in a university or college setting. So we're going to shift a little bit to focus more on practice now. So we've talked about education and preparing. And so what does this look like in practice for a practicing nurse or APN? The first thing I want to highlight is that the World Health Organization has clinical guidelines to support our response to intimate partner violence and sexual violence against women in the healthcare setting. These guidelines are over a decade old. They're currently being updated right now, and are anticipated to come out in the first half of 2026. So please be on the lookout for that. But they are extremely clinical focused. And so they provide some kind of overarching messages and information about women centered care, first line support, documentation, confidentiality, as well as recommendations based on the evidence about things like universal screening, providing psychosocial interventions in the healthcare system, even how to support individuals that might be causing harm. So I would encourage you to take a look at these guidelines as well as watch out for the 2026 guidelines, to really think about how to structure our interactions with patients, and what has evidence behind it and might work in your setting, and then what might not be a best practice. I think for a very long time we thought universal screening, so asking everyone, was the way to go. Now research is showing that might not be as useful in some settings, particularly where there aren't support resources after somebody has disclosed. So again, thinking about how these recommendations apply to your individual setting. As part of these guidelines, the World Health Organization has also developed the Lives mnemonic, and this is really also intended to help guide clinical practice. So when we're interacting with someone who has disclosed some form of violence, whether it be intimate partner violence or sexual violence or something else, thinking about this acronym. So the first step is to listen sympathetically and without judgment. Sometimes this is difficult. We often have short interactions with patients. And so stopping and really giving someone space to disclose and tell their story, and just listen, can be difficult when we're thinking, wow, I only have 15 minutes with this individual. But that's often what they need most, is someone really just to listen to them. Second is to inquire about needs and concerns. And so this step really focuses on, what does the survivor need at that moment? As healthcare providers, we're often focused on the immediate health needs, and that could be something that is of concern for the survivor, but they also might be focused on something that we don't necessarily see as a top priority. And so how can we kind of balance those needs and concerns? I have done a fair amount of work with human trafficking survivors, and many of them are very concerned about kind of job skills and job training so that they can start working kind of outside of whatever they were doing when they were being trafficked. And again, I'm often focused on those immediate health needs, and so how do we kind of balance those two things? The third step is to validate their experience. This really tells the individual that you've heard what they've said, that they don't deserve it, and that you are there to support them. The fourth is to enhance safety. And this is really, again, going to vary on the situation and potentially the setting that you're in. For some individuals, they are not in a position to immediately leave a relationship. They might not feel it's safe. They might have a child or a pet at home that they're concerned about. For others, this could really be, helping them identify immediate support like shelter or kind of legal services or support. So again, this is often a conversation with an adult survivor. When we're thinking about children, this is a little bit different, and often relates to any obligations we have to report some type of child abuse or maltreatment. And then finally, we're going to support by connecting with resources. This is easy to kind of say, but sometimes a little more difficult to do. And so to me, what this final step really highlights is the need to understand what resources are available before you encounter an individual who is experiencing some form of gender-based violence in the health system. So really knowing, are there local shelters or support? What types of counselors or mental health resources are available in your community? What does law enforcement do when you call and say you have a case of sexual violence or intimate partner violence? Are really questions that you want to have the answers to before you encounter a patient who is experiencing harm. The other thing to think about is how you can directly connect someone with a warm handoff. So a patient that is experiencing trauma and harm, their ability to, go look up the information for the name you get them and get an appointment or get to that resource, is often somewhat limited. That is not what they are focused on. They're focused on their kind of immediate safety. And so if possible, can you directly connect them with a resource either by phone or in person, or do you have someone that is able to provide that support? Earlier when we talked about just kind of just the theoretical framing and overarching kind of thoughts related to gender-based violence, I introduced this idea of trauma-informed care. And so this graphic is from the University of Buffalo. Their Center for Social Research does a lot of work on trauma-informed practice within social service settings, but it also applies to healthcare settings as well. So here they have highlighted some of the components of trauma-informed care. So providing safety, and then they talk about what does that actually mean. So creating a welcoming environment. Do we have a private space where someone can have a conversation with you, and it's not just a curtain where they might be overheard, disclosing about the violence they're experiencing? Establishing trust or trustworthiness. How do we talk about violence with someone while also maybe illustrating or talking about the boundaries we have? So things we might have to report, if we're obligated to report, for instance, child maltreatment or other forms of abuse within our setting. The other thing is really just providing clear information and expectations about what the interaction might look like. I know I'm a midwife, and so I do a lot of pelvic exams, and I feel like I'm always kind of over explaining, but that's also exactly what I need to do, right? So, first, I'm going to sit in my chair and I really kind of walk through everything that is going to happen with the interaction for every patient, because again, I don't know who has experienced harm and who hasn't. The third step is choice. So trying to empower our patients with choice when possible. Sometimes this isn't possible in all healthcare situations, but many times it is. And so we often learn our assessments kind of head to toe, and especially when we're first practicing, it's really helpful to maintain, that assessment the way that we learned it. But in reality, we can often kind of do things in a variety of ways and orders within a healthcare interaction. And so some of the ways that this has been done, particularly with sexual assault nurse examiners and SANE exams, I know they really let individuals do as much of the exam as possible. So a lot of it involves collecting evidence or swabs or a piece of hair or whatever that might be, and really allowing the individual to do that on their own. I worked in a sexual health clinic at our local health department, and we also did a lot of self collection, and really let our patients kind of guide those visits and interactions. Fourth is collaboration. So again, this does overlap a bit with choice. How can we really share power and work together? And sometimes this does involve recognizing that there are power dynamics in healthcare interactions. And then the last one is empowerment. And this really focuses on the individual's strengths and capacities. So how can we help support them? Really using person first and inclusive language, and giving them kind of the validity and ability to take on some of the next steps. The one other piece of trauma-informed care or practice that isn't illustrated here is this idea of peer support. And so that's something that's certainly important to consider as we think about resources and next steps for someone kind of beyond that immediate healthcare interaction. When we think about what this looks like as far as outside that immediate healthcare system, we want to think about community organizations and partnering with them for prevention, outreach, and also response. And so this could look like having a relationship with the local shelter so that you understand how they take in new individuals that need support, what that interaction might look like, and even how you can contact them to connect a patient or client with those services. But this can also look like working with other types of community organizations or groups. So, for instance, providing education within schools. I have a 7-year-old daughter, and consent and violence in relationships is something we started talking about very early. That doesn't happen for all children. So how can we sometimes lend our expertise to really help young people understand their body parts, what consent is, what that might look like in relationships. Sometimes different workplaces have programs where we can lend expertise, and again, just thinking about some of the other community organizations that might provide kind of legal support, advocacy, or mental health counseling and support, and how we can connect with them. The last thing I want to focus on is, so we've done the education, we've done the practice. How do we really know if we're making a difference? And I think this is where, the evidence-based or quality improvement projects can be really helpful, as well as the research. What does the research say about some of the best practices for both preventing and responding to different forms of gender-based violence? So, when we think about this monitoring and evaluation, the first is really thinking about what we're trying to change, right? What are the key indicators? I think ultimately for most people, that's eliminating violence. But we also know that's going to take time, and there are steps and indicators we can measure before we actually get there. So, are we increasing safety and well being among the individuals we're interacting with? Are we increasing service uptake? If reporting is a goal, are we increasing reporting? And do we have some improved health outcomes? This could focus on mental health, sexual health, or physical health. The second thing to consider is that we want to ensure we have ethical and participatory methods that engage survivors, but also really respect their confidentiality and safety. This is a time in someone's life where it may not be safe to talk about these experiences. Safety protocols and really thinking about how we engage those who have survived different experiences of gender based harm is really, really important. And then the third piece is rigorous data collection. So this could be, we've looked at our sexual assault nurse examiner program just to see trends in cases. We've looked at, differences in cases over time. For instance, one of the indicators we've looked at is increasing reports of strangulation. And so what does this mean? Where are there areas for prevention and education, but then also response? If somebody is strangled during an experience of intimate partner violence or sexual violence, that could certainly require kind of a different healthcare exam in interventions than somebody who did not have that experience. So I wanted to just kind of walk through a case study and some of the work that I have done with colleagues in Ghana in particular related to gender-based violence. And so I've had the privilege of working with colleagues that are at the University of Cape Coast in Ghana. And one of the reasons we have been focusing on the university is because one, a recent review found very high rates of sexual and gender-based violence within individuals in educational institutions in sub-Saharan Africa. So ranging from 42.3 to 67.7, so much higher than that 1 in 3. We also know that for many of these individuals, they're having the opportunity to get an expanded education and ultimately could become kind of future leaders and policymakers. And so we see this as a really important cohort to educate related to gender-based violence. At the University of Cape Coast, when we started collaborating, they were also establishing a center for gender research, advocacy, and documentation, and they call that SAGRAD. And this was really in response to internal calls, so those within the university community, as well as those in the broader kind of or neighboring communities for ensuring inclusion and equality on campuses. And so when we started working together, they were developing a policy for their university, but really wanted to understand both how to prevent violence among individuals on campus as well as how to respond. Um, and so we engaged in a couple of different projects. And again, this was multidisciplinary. So it included colleagues from nursing, public health, medicine, as well as this center, which included some individuals from different kind of different disciplines. So one was STEM. She was one of the only female faculty in the chemistry department. And really just thinking about what it looks like to have that role in a very male-dominated space. We went through a process called the Adapt It framework, where we took an evidence-based intervention that is used at the University of Michigan to educate incoming students about values, healthy relationships, sexual health, and consent. This next slide is very busy. I don't expect you to read it, but just want to demonstrate that we went through about a 1.5 year long process of actually kind of adapting and testing and kind of responding to those tests and making some more adaptations and changes to get what ultimately became a 1.5 hour long educational program for incoming students, as well as a facilitator training manual so that their peers could be trained to deliver this. Some of the pieces that worked really, really good about this program are that it was a building blocks really based on some very basic premises. So understanding values, consent, information about your own sexual health. And that's where nursing can be so valuable. Comprehensive sexual health education is often missing for a lot of young people. The other really important component is that it was peer delivered. In this setting, not having someone kind of speak down to you about this topic was very important. And then it was also interactive. So we created and adapted activities so that participants were really thinking about what they valued, practicing putting a condom on a banana or something else. So really taking some of these skills and trying to use them. We ultimately ended up with 10 different building blocks that individuals would go through throughout this program. And then we were working with a university administrator. And so this program became a part of the orientation for the university in 2018. It has continued to be peer delivered and delivered as part of the orientation for all incoming students since that time, which is really exciting. But one of the things we've also noticed is that in order to sustain this, there've had to be changes, right? So, it was delivered by peer facilitators. Now they find it's really helpful to have one of the center staff present. And that's really to manage dynamics with faculty or administrators that might try to be in the room with when programming is taking place. They've had to reduce the time significantly, where now it's giving a very good overview, again, introducing individual to resources on campus, but not providing some of those interactive activities that we knew worked. However, through these changes and the ongoing use of this in their orientation, over 30,000 freshman students have been trained with the Camp Life program. The other thing we were able to do with this group is really look at how both the university hospital as well as the community hospital were responding when someone entered the healthcare system. And so we were able to take a really systematic approach to understand both education and resources available and make some very practical recommendations for improving support and care of individuals who have experienced intimate partner and sexual violence within the University of Cape Coast community. So what I want to end on is just really focusing on APNs as frontline advocates, right? So not only are we providing kind of direct care, but we also really can focus on policy, as well as how to engage stakeholders and leverage these global partnerships. And so when we think about progress that we've been able to make related to the Sustainable Development Goals I introduced earlier, there has been a lot better understanding of the health implications for survivors, and in some cases, an improvement in how to provide those services. There are certainly programs that are challenging current gender norms and pushing for gender equality. We have been able to think about access to care in many settings, as well as peace and safety through reform systems. And so, what I will just kind of mention is that the world is changing, and so is the way in which gender-based violence is sometimes occurs. And so, technology is a huge force that we have to consider, both as a way to perpetrate harm, but also as a tool for confidential reporting or potentially telehealth. I've already mentioned comprehensive sexual health education and the role of APNs there. Thinking about disasters and climate change, what this means in our settings and how that can potentially increase experiences of violence. And then also what our roles are in identifying and supporting individuals that might actually be causing the harm. We certainly interact with patients who have caused harm in the health system as well. And so I'll just end with a couple of key takeaways. I do believe that ending gender-based violence is achievable. Otherwise, I would not be doing this work. But it does require education, system change, and partnership. And I think APNs bring unique skills to both those individual kind of patient-centered interactions and interventions, as well as to the systemic and policy ones. And I would love to see us continue to end gender-based violence. All right, I'll go ahead and stop there and see if there are any questions.